includes following diseases, that is chronic obstructive pulmonary diseases COPD is also called as a chronic obstructive airway diseases COAD. So the COPD and COAD includes chronic bronchitis, emphysema, bronchial asthma, bronchiectasis, small airway diseases. So let us discuss one by one. One is chronic obstructive pulmonary disease definition: group of pathological conditions in which there is chronic, partial or complete obstruction to the airway at any level from trachea to the smallest airways, resulting in functional disability of the lungs. And these are also called as a diffuse lung diseases. So COPD also called as a diffuse lung diseases. Common etiologic factor is smoking. Chronic obstructive pulmonary disease includes 5 diseases: chronic bronchitis, emphysema, bronchial asthma, bronchiectasis, small airway diseases. And you can see in the diagram difference between normal lungs and COPD. So in COPD, airway remodeling and fibrosis is there, smooth muscle contraction, airflow obstruction, alveolar hyperinflation, alveolar wall destruction, and loss of elasticity of alveoli capillaries. First, chronic bronchitis. Persistent cough with expectoration on most days for at least 3 months to years. At least 3 months to years for 2 or 3 consecutive years. So this is how this persistent cough should be there for 2 to 3 months, and it should be for 2 to 3 years, consecutive years. The cough is caused by oversecretion of mucus. The condition is more common in middle-aged males than in females. Approximately 20% adult men, 5% adult women have chronic bronchitis. And etiopathogenesis. Smoking is the major etiologic factor, impairs ciliary movement in the lungs. So heavy cigarette smokers have 4 to 10 times higher proneness to develop chronic bronchitis. Second parameter, atmospheric pollution. So pollutants are sulfur dioxide, nitrogen dioxide, particulate dust, toxic fumes. Third parameter causing chronic bronchitis is occupation, where the people are working. Workers in cotton mills, the disease is known as basinosis, plastic factories. So these people will get chronic bronchitis easily. Next parameter is infection. Bacterial, viral, mycoplasmal infections occur secondary to bronchitis. The next factor is familial and genetic factors. Poor familial tendency. So from the parents it is transferring is less. Chronic bronchitis transferring through parents is less. So major etiologic factors are smoking, atmospheric pollution, occupation, working in cotton mills and plastic factories, and infection. Then coming to clinical features, persistent cough and copious expectoration of long duration. Second, initially beginning in a heavy smoker with morning cataract or throat clearing which worsens in winter. Next, recurrent respiratory infections are common. Dyspnea is not prominent at rest but more on exertion. Patients are called blue bloaters. Why they are calling these patients chronic bronchitis patients are blue bloaters means due to cyanosis and edema is observed in the lungs. So cyanosis means that hemoglobin supply decreases. So due to that one, the skin becomes blue, the area of the body becomes blue. So cyanosis and edema, swelling. So patients of chronic bronchitis are called as a blue bloaters due to blue color of cyanosis and edema formation. Features of right heart failure are common in chronic bronchitis patients. X-ray shows enlarged heart with prominent vessels. So enlarged heart with prominent vessels. Emphysema. So second disease, emphysema. The WHO has defined pulmonary emphysema as combination of permanent dilatation of air spaces distal to the terminal bronchioles and the destruction of the walls of dilated air spaces. Emphysema is defined morphologically, whereas chronic bronchitis is defined clinically. Next, patients will be labeled as prominent emphysema or prominent bronchitis. So any patients coming in hospital, they will identify as a prominent emphysema or prominent bronchitis patient. That means this emphysema and bronchitis both occur simultaneously in a patient. So they are giving preference which is maximum, that is prominent emphysema or prominent bronchitis. Next, etiopathogenesis. Commonest form of COPD is combination of chronic bronchitis and pulmonary emphysema. Common etiologic factor: tobacco smoke and air pollutants. So in case of this emphysema, protease antiprotease hypothesis is taking place. So you can see in this emphysema what happens: alpha 1 antitrypsin level decreases in lungs. So due to decrease in alpha 1 antitrypsin, antiprotease decreases. So as the antiprotease decreases, protease increases, which causes elastic tissue damage in the lungs, thereby causing emphysema. So in emphysema, protease is increasing, antiprotease decreasing. Why antiprotease decreasing? Alpha 1 antitrypsin decreases. So thereby, due to protease increase, enzyme elastic tissue damage happens, which will cause the emphysema. You can see the diagram, difference between the emphysema and chronic bronchitis. So inflammation and excess mucus in the bronchitis, whereas alveolar membranes break down in the emphysema. Clinical features of emphysema. Clinical features: there is long history of slowly increasing severe exertional dyspnea. Patient is quite distressed and obvious use of accessory muscles of respiration. So patient is using the excess other muscles of the respiration other than the regular using muscles. Chest is barrel shaped, that means enlarged, and hyper resonant. So he is taking more respiration, inspiration will be more. Cough occurs late after dyspnea starts and is associated with scanty mucoid sputum. Recurrent respiratory infections are not frequent. Patients are called pink puffers, that means PP, pink puffers. So previously chronic bronchitis BB, whereas this one is PP. So pink puffers, as they are well oxygenated and have tachypnea. So these are emphysema patients are called as a pink puffers. Weight loss is common in the emphysema patient. The features of right heart failure and hypercapnic respiratory failure are usual terminal events. Chest X-ray shows small heart and hyperinflated lungs. Classification of emphysema. Emphysema is classified into two groups: true emphysema, overinflation emphysema. So true emphysema, overinflation emphysema. So first, true emphysema is again 5 categories: centriacinar emphysema, also called centrilobular. So let us discuss as a lobular: centrilobular emphysema, panlobular emphysema, distal acinar emphysema, irregular emphysema, mixed emphysema. So first one, centriacinar emphysema. So these are all affecting acinus. So acinus is a spaces in the lungs. So lungs alveoli. So first, centrilobular emphysema, central or proximal part of acinus is affected. Central or proximal part of acinus is affected in centrilobular emphysema. Whereas second, panacinar emphysema, all portions of acinus affected. So that is panlobular emphysema, all parts of acinus affected. Whereas distal acinar, so distal acinar emphysema, distal part or lower part of the acinus involved, affected. So you can see in the diagram also normal bronchial how it is there, whereas centriacinar central part enlarged is there, paraseptal at the terminal enlargement is there, paraacinar, that means entire port completely all part of the bronchial is enlarged, irregular. So diagram also showing how different is centrilobular, panlobular, distal acinar, and irregular and mixed emphysema. So 5 different emphysemas are discussed here. Then coming to overinflation emphysema. So this is other group, overinflation emphysema. Again it is having 4 groups: compensatory overinflation, also called as compensatory emphysema. Second one is senile hyperinflation emphysema, obstructive overinflation emphysema, unilateral emphysema, are also called as the interstitial emphysema, surgical emphysema. So let us discuss all these things one by emphysemas. And here you can see in the diagram, centrilobular emphysema is the common emphysema. Most common type of emphysema is centrilobular emphysema. So central part of sinus is affected. Overinflation emphysema, you can see 5 types. Compensatory overinflation emphysema, you can see wherever red is there, highlighted points, you can see lung is surgically removed. So compensatory overinflation emphysema, lung is surgically removed. So this as a compensatory mechanism, lung parenchyma undergo hyperinflation, so has to fill the pleural cavity. So this is the first. So compensatory overinflation emphysema, lung is surgically removed, so lung parenchyma undergoes compensatory inflation. Second, senile hyperinflation emphysema. So in senile hyperinflation emphysema is old people. So in old age peoples, this elastic tissue, lung elastic tissue loses its capacity and atrophy of the alveolar ducts and alveoli is taking place. So senile hypersema is observed in the senile hyperinflation emphysema is observed in the old people due to elastic tissue damage. Third one is obstructive overinflation emphysema. So here obstructive overinflation emphysema due to tumor or by foreign body. So there will be obstruction in the bronchial trunk due to the tumor or foreign body. So this causes the inflation emphysema. So obstructive overinflation emphysema. Unilateral translucent emphysema. So as the name itself indicates, unilateral means a single lung or one small part of the lung is involved. So you can see one lung or one of its lobe, that means lungs one lobe or segment of a lobe is radiolactant. So that means here you can see emphysema in the single lung or one lobe of the lung or one segment of the lung. So specific area is involved. So unilateral translucent emphysema. So next, surgical interstitial emphysema. So surgical interstitial emphysema, if you see the definition, the entry of air into the connective tissue framework of the lung is called interstitial or surgical emphysema. That means this is mainly caused in the surgery times. So causes for surgical interstitial emphysema: violent coughing with bronchiolar obstruction. So due to asthma for long duration, violent coughing with bronchiolar obstruction. Rupture of esophagus. So whatever the food we are taking, so esophagus rupture is happening, due to that one this is affecting the lungs. Then lung trauma, so lung damage due to accident. Entry of air through surgical incision. So during incision, due to some or the other way, air entry happens. So entry of air through surgical incision. Fractured rib puncturing lung parenchyma. So fractured rib damaging the lung parenchyma. So here you can see the lung trauma due to the damage of esophagus or due to surgery or due to some of the fractured rib compressing the lung, so thereby causing the surgical interstitial emphysema. Third disease is bronchial asthma. So this bronchial asthma characterized by increased responsiveness of the tracheobronchial tree to a variety of stimuli, resulting in widespread spasmodic narrowing of the air passages, which may be relieved spontaneously or by therapy. Asthma is an episodic disease manifested clinically by paroxysms of dyspnea, cough and wheezing. So this asthma, you can see here, episodic disease, that means suddenly lungs respiration decreases, increases, so that sudden changes is happening, so episodic disease. Next severe form of asthma is called as status asthmaticus. It will be fatal, proved to be fatal, that means it may cause death in certain cases. Occurs at all ages. Bronchial asthma occurs in all age group. 50% cases develop it before the age of 10. In adult, both sexes are affected equally. In children, male female ratio, if you see, males children ratio 2:1. That means male children are more affected than the female children. Then etiopathogenesis of bronchial asthma. If you see etiopathogenesis, either type of asthma can be precipitated by cold, exercise and emotional stress. So asthma is two types, intrinsic and extrinsic asthma. So we will discuss in next slide. So both types of asthma precipitated by cold, exercise and emotional stress. Then microscopically, if you see, the mucus plugs contain normal or degenerated respiratory epithelium forming twisted strips called Kirschmann spirals. So I will repeat, the mucus plugs contain normal or degenerated respiratory epithelium forming twisted strips called Kirschmann spirals. So Kirschmann spirals are degenerated respiratory epithelium cells. So these are twisted in shape, strips. So this will be observed in microscopically in the bronchial asthma patients. The sputum usually contains numerous eosinophilic and diamond-shaped crystals derived from eosinophils called Charcot-Leyden crystals. So Charcot-Leyden crystals are eosinophilic diamond-shaped crystals. So these two characters are major for identifying bronchial asthma: Kirschmann spirals, Charcot-Leyden crystals, eosinophilic crystals. Next, hypertrophy of submucosal glands as well as the bronchial muscle, smooth muscles will be observed. So hypertrophy of submucosal glands as well as the bronchial smooth muscle is observed. Next, clinical features of bronchial asthma. Asthmatic patients suffer from episodes of acute exacerbations interspersed with symptoms-free periods. So suddenly coughing will come, it decreases, again coughing will come. So it is called acute episodes of cough. Characterized clinical features are paroxysms of dyspnea, cough and wheezing. Then dyspnea means decreased respiration, cough and wheezing. Most attacks typically last for a few minutes to hours. So it may last for asthma for a few minutes to hours. When attacks occur simultaneously, it may result in more serious conditions called status asthmaticus. So it may cause status asthmaticus if it is asthma retained for long duration, more than 5-10 minutes. Clinical diagnosis, how they are identifying asthma: demonstration of eosinophilic circulation, sputum demonstration of Kirschmann spirals and Charcot-Leyden crystals. More chronic cases may develop cor pulmonale, that means coronary pulmonary diseases. So severe lung diseases may happen with the bronchial asthma. So here normal lungs and asthmatic lungs, you can see the difference. Next, difference between the two asthma types of asthma, contrasting features of two major types of asthma: extrinsic asthma, intrinsic asthma. So first, one by one parameter we can discuss. Age at onset: extrinsic asthma in children, intrinsic asthma will be observed in adults. Then coming to personal or familial history, extrinsic asthma is commonly present familial history, whereas intrinsic asthma no familial history, absent. Preceding allergic illness, that means previously having any allergic illness, so it will be present in the child, that is extrinsic asthma present, rhinitis, urticaria, eczema will be present, whereas absent in the intrinsic asthma. Allergens, so allergens are normally present in the extrinsic asthma. Examples of allergens means dust, pollens, dandruff, etc. Whereas intrinsic asthma no allergens. Next, drug hypersensitivity. No drug hypersensitivity for the extrinsic asthma, whereas drug sensitivity will be there for intrinsic asthma. Drug allergy, due to drug allergy, intrinsic asthma will be happening in the patient. Serum IgE level, that means immunoglobulin E. Serum immunoglobulin E elevated in the extrinsic asthma, where serum IgE level will be normal in the intrinsic asthma. Associated chronic bronchitis, nasal polyps are absent in the extrinsic asthma, whereas present in the intrinsic asthma. And important point, emphysema. So unusual. So unusual emphysema in extrinsic asthma, common in the intrinsic asthma. So in the childhood, extrinsic asthma will be observed, intrinsic asthma in the adults. Familial history and allergic reactions, then drug hypersensitivity, IgE levels, associated chronic bronchitis, all this will be considered parameters for differentiating extrinsic asthma and intrinsic asthma. One is chronic obstructive pulmonary disease definition: group of pathological conditions in which there is chronic, partial or complete obstruction to the airway at any level from trachea to the smallest airways, resulting in functional disability of the lungs. And these are also called as a diffuse lung diseases. So COPD also called as a diffuse lung diseases. Common etiologic factor is smoking. Chronic obstructive pulmonary disease includes 5 diseases: chronic bronchitis, emphysema, bronchial asthma, bronchiectasis, small airway diseases. And you can see in the diagram difference between normal lungs and COPD. So in COPD, airway remodeling and fibrosis is there, smooth muscle contraction, airflow obstruction, alveolar hyperinflation, alveolar wall destruction, and loss of elasticity of alveoli capillaries. Third disease is bronchial asthma. So this bronchial asthma characterized by increased responsiveness of the tracheobronchial tree to a variety of stimuli, resulting in widespread spasmodic narrowing of the air passages, which may be relieved spontaneously or by therapy. Asthma is an episodic disease manifested clinically by paroxysms of dyspnea, cough and wheezing. So this asthma, you can see here, episodic disease, that means suddenly lungs respiration decreases, increases, so that sudden changes is happening, so episodic disease. Next severe form of asthma is called as the status asthmaticus. It will be fatal, proved to be fatal, that means it may cause death in certain cases. Occurs at all ages. Bronchial asthma occurs in all age group. 50% cases develop it before the age of 10. In adult, both sexes are affected equally. In children, male female ratio, if you see, male children ratio 2:1, that means male children are more affected than the female children. Then fifth disease is small airway diseases. So small airway diseases, two names you should remember: bronchiolitis, bronchiolitis obliterans. So two diseases, bronchiolitis and bronchiolitis obliterans, are the inflammatory conditions affecting the small airways. Occur predominantly in older pediatric age groups. So this is in pediatric age groups you can see. Etiologic factors: viral infections, that frequently adenovirus and respiratory syncytial virus, bacterial infection, fungal infection, inhalation of toxic gases, example insulophilus diseases, silicon gases. Then aspiration of gastric contents. So aspiration of gastric contents means stomach contents moving to the lungs, small amount to the lungs. So aspiration of gastric contents causes the small airway diseases. Then etiopathogenesis of bronchial asthma. If you see etiopathogenesis, either type